Brilliant. So I think we'll kick off then and make a start. I can see that there's a number of participants joining, so I'm just going to let people join for 30 seconds and then I'll kick off the meeting. Brilliant. So welcome everyone. It's absolutely fantastic to have you join us for the Respiratory Data Catalyst Science Catalyst even webinar. Really pleased that you've all joined. I'm Jenni Quint. I'm a Professor of Respiratory Epidemiology and the Associate Director of the Respiratory Data Science Catalyst. So I've got a number of people with me today. So I've got David Seymour, who's joined us from Health Data Research UK. He's Director of Data Partnerships. Sarah Sleet, who's the CEO at Asthma and Lung UK, and Victor Cholij, who's a patient representative from Asthma and Lung UK. I'm just going to do a little bit of housekeeping before we start on the agenda. So just so that everybody's aware, this session is being recorded and we will send round a link to the recording via email after the meeting. We are going to be monitoring the audience, so any artificial intelligence assistants in attendance who are transcribing or recording the meeting on somebody's behalf will be removed because there isn't permission to do that. We've got plenty of time for questions at the end of the presentation, so please use the Q&A function in Zoom to ask questions as you think about things as we go through the various presentations. Otherwise, there'll be a lot of filling to do at the end, and who knows what we'll end up talking about. So please do put your questions in the Q&A. If we have lots of questions and don't get through all of them, we will do our best to send round answers via email at the end of the webinar. So the way we're going to do things for the next hour, so I'm going to start by asking David Seymour to give us a bit of an introduction around Health Data Research UK. I'm conscious there's quite a broad range of people who've signed up for this webinar today, so I just want to make sure that by the time we talk about the data catalyst that everybody's on the same page. So after David, Sarah's going to talk a little bit about Asthma and Lung UK and their perspective on the data catalyst. I'll then talk through the vision and the strategy for the Catalyst and the things that we've been up to already since it was officially started on the 1st of July of this year. And Victor's going to talk about things from a patient and public perspective. So with that, David, I'm going to hand over to you and let you talk about HDR UK, please.
Jenni, thank you very much indeed. Delighted to be here. I will go forward and hopefully share my screen. That's hopefully coming up now for people. So as Jenni pointed out, I'm David Seymour. I'm Director of Data Partnerships at Health Data Research UK. Health Data Research UK, or HDR UK, is the National Institute for Health Data Science. It was established in 2018 by a set of core funders, and we're funded for sort of five-year blocks of time. And I really just want to sort of step through today really about our mission and vision and how we sort of organise ourselves, and I guess within this context how the Respiratory Data Science Catalyst sort of fits into that. So I'll just move through a few slides to sort of bring you orientate you to Health Data Research UK. So overall, our mission, as you can see on the screen there, is to accelerate trustworthy use of health relevant data to enable discoveries that improve people's lives, within the context of a 20-year vision, which is that large-scale data should benefit every interaction with patients, clinical trials and biomedical discoveries, and so transform public health over that period. We work in partnership with the NHS, with industry, with charities and universities to realise the potential of the UK's health data and health relevant data in life-changing research. And patients and the public are actively involved in shaping HDR UK's work, both through our public advisory board, but also through all of the different programmes and projects that we're involved in, where we want to make sure that there is public and patient representation across each of those to ensure that it is delivering public benefit and focused on what's most important to people. As mentioned, we're funded by a set of 9 core funders that you can see the logos of at the bottom across UK R&I, medical research charities, the large ones of that, and across the 4 nations of the UK. we've got 3 strategic objectives, and I think hopefully you can see also how the Respiratory Data Science Catalyst sort of also fits into each of these three things. So first and foremost, we want to accelerate trustworthy data use by helping and working with others to sort of sort the data to make sure it's available, accessible, and reusable. Secondly, we want to actually prove out the data, I guess, if you want, with doing research that improves people's lives, to demonstrate the power of the data and really by unlocking the potential within that. And thirdly, actually, we know we need to shape the future of the health data research. People will be very aware through, obviously, artificial intelligence, as mentioned by Jenni earlier. There's huge changes happening across data, and the growth of the actual availability of data is tremendous over the last sort of 10 years and beyond. And therefore, it's really important that the future of health data is sort of shaped to enable that trustworthy use. And within that context, we sort of see a maturing of the sector, really where you move from really research collaborations, which would have one-to-one data custodian to sort of research data set relationships. And through that sector maturity and through things like secure data environments, we're seeing many-to-many sort of relationships going on. So data custodians coming together to really realize the power of linkage, and then many researchers collaborating together in programmatic ways to really share the benefit of their knowledge, but also benefits of things like code sharing, etc. And to do so, they need secure data environments or secure research environments to work within. So a lot of Health Data Research UK's work is around really enabling activities to make sure we've got consistency of information governance and policies, consistency of standards, interoperable technology and data, all the time thinking through how do we accelerate the use of data for public benefit. And when we talk about the data, we're talking about a whole range of different, what you might describe as multimodal data. So a lot of the focus, and many of you may be hopefully familiar with nationally collected population-wide data. So this is things like hospital episode statistics or its equivalent in the devolved nations. But this is also about sort of cancer registration data and also any other data assets that are collected around mental health, maternity care, imaging that is collected at national level. How do we make that available and reusable across the 4 nations? But how do we also take that to augment it with data that might only be available within a local NHS trust, whether that's large imaging data sets, whether that's increasingly genomic data, laboratory test results, or even all of the rich information that's included within things like free text or the sort of text documents that might be your discharge summary or might be referral letters, again, that is sort of sensitive but kept locally. You've then got a wealth of other administrative data sets and organisations like Research Data Scotland, Administrative Data Research UK, Office for National Statistics, an exemplar within Wales, the Sale Data Bank, really sees how we can bring together census, education, disability, income-related data. So all of that, if you want, is almost like data that's collected for its primary purpose and then reused for research. Across the bottom, we've got data again, which might be generated through research projects, such as in the bottom right-hand side, with large cohorts such as Our Future Health, UK Biobank, Genomics England, or it might be environmental data, and so that could include weather, it could include air pollution, obviously, which is hugely relevant to respiratory disease, and then also personal monitoring data, which could be club card related, but also is the data that you'd get from wearables, smartwatches, etc., like that, which again, looking at activity levels and its importance within disease progression and also treatment strategies. So if you look at that sort of visually, what we're talking about really trying to enable over that 20-year vision is that we can get across the whole of the UK and ideally beyond, that we increase the level of sort of diversity and detail within that data, so accessing this multimodal data concept, and that we can do that across essentially the cradle to grave across the lifespan. And obviously key for that is being able to sort of access and use in a trustworthy and safe way primary care data. So I think fair to say it's sort of we're making progress. I think the pandemic, for all of the negatives around it, it really did enable an explosion in sort of use of large-scale linked data for public benefit at incredible scale. And really just wanted to highlight one of the sort of, I suppose, achievements around this, which is the Cholij study, which was the UK's first study of over 67 million people, again, achieved through use of trusted research environments, getting whole nation coverage, and looking at data from primary care, from hospital, from vaccinations, from COVID-19 test results and death registry. And that by analysing that in a consistent way across the 4 nations, was able to identify the level of under-vaccination across the UK population relevant to the sort of vaccine sort of strategies or sort of ideal levels of vaccine coverage. And that identified a number of potentially preventable severe COVID-19 outcomes. And that research actually has been updated relatively recently by the team, and it featured in Sunday's Observer that you can see there, whereby drilling down to even short, sort of smaller sort of ethnic groupings, there's even greater diversity and inequality in terms of vaccine uptake. So again, you can only achieve that level of sort of fine-grained analysis if you've got large-scale data across the country. So in terms of the sort of HDR UK and what we've got in place, I guess, to help deliver against the mission and the vision, we've got leadership from across 39 different research organisations. So we're a virtual institute across the UK with 9 sort of regional and national networks covering Wales, Scotland, Northern Ireland, and then regions within England. And our aims through that is to make sure we're connecting with the NHS in particular as key partners within this endeavour, but also then we're opening up that regional and national capability in infrastructure and data, but also in the research capabilities. One of the things you'll get here talked about, if you're not already familiar, is a thing called FAIR data. So this is findable, accessible, interoperable and reusable data. And one of the things we're trying to put in place within Health Data Research UK is that infrastructure and services that allow research and innovators to get access to timely data. It allows data custodians to make their data fair, and also it enables transparency and real reuse of that data by the public, by practitioners and by policymakers. And you can see in the chart there in the middle some of the sort of the services and the programs that are running and relevant to this space. I say particularly the Health Data Research Gateway and its services allows that data discovery and increasingly data accessibility. Work around data standards helps us with interoperable data, and things like data curation activity and transforming data for trials ensures it can be reused for all those purposes. But the people dimension of this is really important too. So actually the capacity building activities which cover academic programs such as masters and PhDs, but also then just-in-time learning through things like HDR Futures, but also opportunities such as the Black Internship Programme, really trying to build our human capacity in health data research. And to actually prove out that it's all working, we've got 5 different driver programs currently covering different linkage of data assets. So molecules to electronic health records is very much about bringing that genetic data alongside the hospital record and other sort of primary care records. Inflammation and immunity, I'm sure we'll get mentioned further on, is about connecting those different data that's available around inflammation to enable improvements in health. Focus on medicines data in driver program 3 and connecting that so we can enable improvements in care, in treatment and safety. We've got work on social and environmental determinants of health, which again, highly relevant to respiratory disease in terms of how do we bring that environmental data alongside and link at the sort of the place-based nature. And then also big data for common and complex diseases. So looking at cancer, cardiovascular disease, dementia in that space as initial aims. All of that with the aim of delivering impact, but also leaving behind data foundations that can be reused by other research groups. And so just to close on this, really I wanted to highlight how the Respiratory Catalyst fits in and benefits from working closely with related initiatives. And big focus here is at the British Heart Foundation Data Science Centre. And you can see there it's different thematic areas across the whole population data through to defining diseases or phenotypes. Over the last couple of years, we've established 3 additional data science catalysts, or 3 of the first data science catalysts covering diabetes, kidney disease and stroke. And it's wonderful now to bring to the mix Respiratory Data Science Catalyst in partnership with Asthma and Lung UK, so that we can really build on previous investments in the Breathe Health Data Research Hub and ongoing work in the driver programme of inflammation and immunity. So I will stop there. I'd be very happy to answer any questions later on. And I believe I should be handing over to Sarah to provide the Asthma and Lung UK perspective.
Thank you so much, David. Yes, so as you heard at the top end, I'm Sarah and I'm the CEO of Asthma and Lung UK. absolutely delighted to be here, the inaugural event for the new Data Catalyst, because it's going to be fundamental to driving change for people with respiratory conditions. And I just wanted to touch on the size of the issue, because I'm fairly new to respiratory. I only joined the organisation in April, but I have been truly shocked at the scale of the challenge faced by people with respiratory conditions, lung health issues. 1 in 5 of us will get a respiratory condition in our lifetime, so it's not uncommon. It's the 3rd biggest killer in the UK. And we also know that we have the worst outcomes in Europe. We are a long, long way behind where we should be. And it's also probably one of all the major conditions, the most impacted by socioeconomic deprivation. So if you have a common condition like COPD, chronic obstructive respiratory disease, pulmonary disease, you are 5 times more likely to die of that condition if you're in the bottom or the worst off people in this country compared to those who are in the better off groups. If you have asthma, you're more than 3 times more likely to die. And I could recite stat upon stat that shows essentially the massive differential between those who are worst off and their experience of not only being getting diagnosed or not getting diagnosed quite often, getting the treatment and their outcomes from that treatment, and eventually mortality. So the scale of the problem for the UK is huge. But in common with many other conditions, which are often long-term conditions and often progressive, it's actually very difficult to disentangle all of the variables that affect those conditions over somebody's life trajectory. And the only way of doing that and picking out the signals in terms of what is going on is by having very large data sets where you can link up and you can look for those sometimes quite small variables which are impacting on your life. And for respiratory conditions which are very affected not only by genes and by other triggers, but environmental triggers and experience of the health service will be really, really difficult issues to disentangle. And by joining up data, we can start to do that. Now, in terms of data research generally, we know that, once again, lung health is quite a long way behind. And from that slide that you saw from David, where the British Heart Foundation and heart disease has been at this quite a long time, and then recently kidney diabetes and stroke, and now finally respiratory is coming along behind it. We think this is going to be game-changing for us. We know that in terms of investment in research for respiratory, again, we're a long way behind. Something like we estimate, compared to the impact of the conditions, something like 6% of public funding should be going into respiratory, and actually only 2.5%. And what that means in numbers terms is we should be having about £150 million investment a year, and we're only at round about 50 odd million. So it's great to see this programme coming forward and putting that investment in, which will in its turn drive interest and investment in broader research for respiratory conditions, because it's going to be an essential platform to do that. So the charity is really supportive of this initiative. We are investing ourselves about £500,000 over the next few years to support the programme. The money is relatively small, but I think probably one of the biggest things that we can do with this programme is really power, play the power of the patient, be able to support and invest in our enthusiasm, our access to patients, our support in terms of people and the public getting involved in this work. So I'm really, really pleased to be able to do that. Finally, I would just say that from the point of view of patients, and I think sometimes in data research, there is a concern that patients may be worried about the safety of their data and the use of their data. In my experience working with patient organisations in conditions that are often underinvested and under-resourced, actually patients are incredibly keen for their data to be used and to be joined up and to start producing results. So I would say that in the case of respiratory, this is something that is going to be, again, very much supported by the patient community, who we will be urging to get involved. And I think you're going to hear much more about that from my colleague who I work with, Victor, who you will be hearing from in a moment as a patient perspective. And then finally, I just wanted to say, we've talked a lot about the impact of data on research, and quite often we think about that in terms of medical research. But data is also fundamentally important to driving quality improvement within the NHS. And again, we know that the lack of data collection, sometimes it's lack of data collection, sometimes it's lack of quality data collection, and it's certainly a lack of linkage between data, is really holding back quality improvement in the NHS. There are some great examples of data collection in very specific circumstances, but what we haven't got is that uniting of data sources from the various different angles. Somebody was showing me a couple of days ago a graph which showed the various elements, the kind of domains of data that you need to collect across the touch points for a patient in terms of their interaction with the NHS and over their lifetime. I think there was something like 15 domains. And when you compared respiratory against other major conditions such as cardiovascular, cancer, dementia, once again, we are way behind there. We probably only have good data in about maybe 5 of those. And we are missing data in 6 of those. And unless we're able to fill those gaps, we won't be able to say whether where we're failing in terms of delivery of service, whether interventions are good interventions or worthwhile interventions, and where we can make a big difference to patients' experience. So it's really important that we can fill those gaps and we can get those linkages in terms of quality improvement. And finally, the difference that makes is when you look at improvements in health in terms of the major conditions over the last few years. Over the last 20 years, mortality in cancer has dropped by something like 50%, 58%. In respiratory, it's only dropped by 18%. We are massively behind, but I'm so excited that we've now got this platform to really drive our respiratory conditions improvement forward. So thank you very much, and I'm going to hand back to Jenni now to move on. Thank you, Jenni.
Thanks very much, Sarah, and a huge thanks to David as well. And hopefully that's provided background to everyone so that you understand where the Catalyst is coming from and what the basis behind it is. And hopefully you can see my screen now and my slides. So what I'm going to do in the next 15 to 20 minutes is go through the strategy for the Respiratory Data Catalyst and our high-level plans for the Catalyst, which is funded for 3 + 2 years. So I'm going to talk a little bit about how the Catalyst is going to help patients and how we're going to be able to transform outcomes. Talk a little bit about how people can use data from the Catalyst and work collaboratively with the Catalyst. And most importantly, at the end, we've left plenty of time for Q&A because I'm really keen to hear people's ideas, get some feedback, and understand a bit more about how we can make this as useful as possible to researchers, clinicians, patients, etc. So the overarching vision of the Catalyst is essentially to facilitate data-driven research by using linked multimodal patient data at a national scale so that we can address major respiratory research questions that are relevant. Our strategy is ultimately to transform respiratory outcomes by providing high quality data, making it as accessible as possible to researchers and policymakers. And where data aren't accessible through us for various governance reasons, that we're able to facilitate sharing code and algorithms to make use of that data as easy and as straightforward as possible. One of the things that I would love to be able to achieve is just broadening out the number of people who are using data in the longer term, both from a clinical standpoint in day-to-day decision making, as well as thinking about it from a research standpoint. We're looking to develop projects across Health Data Research UK programmes. So David's already mentioned a number of other programmes across HDR UK through which the Catalyst will benefit in terms of resource and work that's been done more broadly to begin with. But we're also looking to feed into that and help to improve the quality of any respiratory things that are being studied across those various programmes. I really want the Catalyst to be very collaborative. We've already started working very closely with NICE and with NHS England and with some wider international programmes of work around data standardisation, in particular a programme called Standout, which is being partially funded by AstraZeneca, and I'll talk about that a little bit later on. And the final aspect of our strategy is to facilitate collaboration. I've already alluded to the importance of collaboration in making this successful, which is why I'm so keen to get feedback from people today, because this is only going to be valuable and worthwhile if it's valuable to the wider community. And I think if we can work together and do all of these things, we can ultimately improve respiratory health outcomes and help to improve the funding that's available for respiratory data and research. So our specific aims are to help to improve the quality and the accessibility of data. Sarah's already alluded to the fact that sometimes data is available, but it's not particularly of high quality. How can we make the most of what we have available to us to provide analyses that are as robust as possible to enable us to do the best work? And how can we then use that to look at causes, consequences, and management of respiratory disease? So we're going to look to provide toolkits to be able to help people to access data of the highest quality. We want to be able to accelerate existing work that's taking place by helping people to be able to access data. And that might be people not knowing that certain data assets exist and that they're able to access them or how to access them. In addition to being able to help to improve linkages as well as analysis to support better respiratory research. And in doing this to help not just Asthma and Lung UK's strategic objectives, but also the wider respiratory community's objectives in terms of research and innovation. We are very keen to expand and include wider people in terms of strategic positions within the data catalyst and resource, and I'll talk a little bit about some opportunities to get involved a little bit later on. And ultimately, we want to speed up the way things are being done, so high value, high quality, fast pace outputs to improve the lives of people with respiratory disease. So in writing the data strategy, we've come up with 9 different core themes, and I'm going to talk through each of these themes in a little bit more detail over the next few minutes, as well as providing some examples as to where we are or what we've done or what we're planning to do in terms of bringing these themes to real life. But essentially, it's around development of dashboards, how we can better use population health systems data. And this goes back to some of the comments that David was making around Health Data Research UK and the availability of population level data. how we can better define respiratory diseases and respiratory disease consequences. So thinking about the way in which we're using the data so that we're all saying the same thing from the data and not contradicting ourselves. Looking for newer opportunities in terms of respiratory data. So David mentioned environmental data earlier. I know broadly in the respiratory community, even getting access to things like spirometry data can be really challenging. So how can we potentially help to facilitate and ease some of that? Working with other partnerships that are available around smartphone and wearable data, particularly around prediction modelling and thinking about respiratory exacerbations. Thinking about broadening trials and how we might be able to use respiratory routine data to be able to help to enhance follow-up in the longer term. Provide some training for researchers and clinicians, trying to get everybody on board with whatever angle it is they're coming from with better using the data. And then, as I've already mentioned, and we'll hear a little bit more from Victor a little bit later on about how we're involving patients and the public within the Respiratory Data Catalyst. So just starting with the first theme then, and dashboards, our plan is to be able to enable people to find accurate high-level respiratory metrics for things that are really straightforward, like incidence, prevalence, and mortality of common respiratory diseases. The last time I've seen these data was the 2012 update on what was the British Lung Foundation website in terms of being able to look at disease broadly across the country and then split by sex, ethnicity, deprivation, etc. So things which are common, which we all want at our fingertips when we're writing grant applications or being able to put in business cases in terms of improving clinical services, often just aren't as accessible as they should be. So we're going to do this by building on work that the Breathe Data Hub that David already mentioned started with, and the Inflammation Immunity Driver Programme then carried on with, doing some curation work around how to best define diseases and create these dashboards so that we can describe things in near real time. So all of the methodology has been done now across the chronic respiratory diseases, so COPD, asthma, bronchiectasis, and interstitial lung disease. And we're now looking at where can we host that and post the information and update it 6 monthly, in addition to stratifying these high-level incidence and prevalence and mortality dashboards by ethnicity, deprivation, and sex, and making them available to the wider public, researchers, clinicians, and policymakers. And in the true spirit of collaboration, I'm well aware that the Asthma Lung UK Task Force has commissioned some dashboards to be made. NHS England on their respiratory futures pages have a number of respiratory dashboards. What we're looking to do is to try and bring these things together, make sure that the methodology is robust and similar across how all of these dashboards are being made, make sure that people know how to access them, where to find them, how to use them, and then we will fill in the gaps with the Respiratory Data Catalyst that need filling in. This isn't about duplicating work that's already ongoing. It's about bringing things together so there's one spot that people can go to know where they're then able to find these things, but being able to ensure that gaps get filled in as well. The second example really then is around expanding how we're going to do things with population level health systems data. And the real rationale behind this is both from a clinical and a research standpoint, and that is that there is a wealth of data that's increasingly available, and it is being used increasingly to form policy, to form clinical practice, and for research purposes. But a lot of the time people will say to me that they don't necessarily know where they're able to find data, how to access the data. Even people who've done lots of work with data before don't necessarily know about new updates with and new data sets that have become available. So we want to be able to support researchers and support respiratory data science researchers to use a variety of data sets, and where possible, has been mentioned before, to make data sets available to researchers to help to support their projects, but where for various data governance reasons we're not able to facilitate the access itself, to be able to help people in terms of signposting for exemplars of application forms, code lists and algorithms, so that people can really hit the ground running and start to use these data sources much more robustly, quickly than they can do at the moment. And to make sure that, as with all of these things, because there's been so much interest and money invested around cardiovascular disease and cancer, that these things have a very specific respiratory flavour to them. And we want to ensure that by working closely with patients and members of the public, that we help researchers to identify and prioritise the most important questions to be answered. And we will be doing exactly the same with specific questions that we're looking to answer with the data. So some examples of what's been done around this. So in collaboration with Asthma and Lung UK, Health Data Research funded a number of master's projects, and I'll talk a little bit about that later on, to specifically support projects in respiratory data science. We are in the process of building a community of practice to help people to collaborate more together, to be able to answer important respiratory questions. And we are looking to promote the recent Asthma and Lung UK call that they've put out for respiratory data projects specifically, and also to help with use of data around the National Respiratory Audit Programme, and where that data and how that data can be accessed and used. And we will be looking at having our own funding calls in the future. So our next strategy point was thinking about defining respiratory diseases and respiratory disease consequences. And the rationale behind this is that there is no standardized definition of disease or disease outcomes. And we know that using different definitions leads to different results. So even something as straightforward as prevalence, depending upon code sets that you use in primary and secondary care, you can end up with completely different prevalence estimates and then prevalence trajectory estimates as to what you think is going to happen with respiratory disease. And as a community, when we have mixed messaging that comes out of this, we end up weakening our own voice in terms of trying to explain to government and policymakers the importance of using respiratory data. So we're looking to input into wider programs of work to agree common definitions to be used across respiratory diseases. So I mentioned Standout earlier. This is actually a global group of individuals who've come together who are looking at standardizing how outcomes are coded in routine sources of data and aligning that with cohort data and registries where data are collected in a primary fashion, so that we've got common definitions across things. And just a couple of other examples. So we will work very closely with NHS England and the development of their respiratory data strategy, which was launched to the NHS England Respiratory Board just this last week. And the respiratory data strategy within NHS England is looking to provide consistent metrics to improve outcomes for people, improving clinical care and the use of data for trials and observational studies. Importantly, to allow monitoring of the impact of changes associated with long-term plans. And of course, if we measure things in different ways each time we measure it, then we're not sure if what we're implementing is actually what's making a difference in terms of seeing differences in prevalence or exacerbations, for example. So this is also the reason for the importance of consistency across how we measure things. And also to help to alleviate concerns, particularly from a clinical standpoint, over data quality and data management. And another example is the pulmonary rehabilitation patient finding and prioritization tool, which was developed by MTech using routinely collected electronic healthcare record data, underpinning the basis of the development of that tool with NHS England. So the data is being used already, and we're just trying to ensure that we can help people to access this as easily as possible. And I'll talk a bit more about access when I talk about training later on. But it's not just the sort of routine healthcare data that sits in primary care and in secondary care that's important. There's a wealth of opportunity, and particularly in respiratory disease, thinking about imaging data, so chest x-rays and CT scans. And I mentioned earlier the importance of spirometry data, how we can better obtain and analyze some of this data. So one of the things that we're doing early on is working with the Scottish medical imaging data set, which has already been used across HDR UK for other purposes, to help to compare some nodule radiology algorithms and looking specifically at respiratory disease and how we can use this data better from a respiratory standpoint. And also working very closely with NHS England, thinking about how we can help people to better find spirometry data, learning what we've learned through the National Respiratory Audit Programme about codes that get used for spirometry, helping to develop common templates, and helping people to be able to interrogate their own data locally so that they can look for spirometry information. So these are the examples I've already started to talk about a little bit. So one of the things that we will do specifically as part of the Catalyst is work closely with NHS England around training ICBs and clinicians around not just how to use their own spirometry data locally and standardising how people do that, but also looking more broadly across the NHS England dashboard and how people access the dashboard and how and where they find information and how they can then use that to their best advantage locally. The next example that I've got is around using smartphone and wearable data to measure specifically respiratory exacerbations. We know there's a wealth of data that gets collected from personal devices, which can be extremely useful in terms of better understanding respiratory outcomes and respiratory measures. So we're going to work very closely with Will Dixon, who has an MRC partnership grant based up in Manchester called Health Research from Home, where he's specifically looking to look at how people are using data and help to develop standards from wearables and these other tech devices. And we'll be helping with that from specifically a respiratory data standpoint. Next, we're looking at how we enhance follow-up and respiratory healthcare data. Trials are increasingly expensive. We're looking at how we can link both registry data, cohort information with routine healthcare data. And the example here is we've been working closely with the UK Severe Asthma Registry, helping to facilitate linkage with primary care data. And I've started already to talk a little bit about trials. We want to start to look at how we can more efficiently use data both for longer term follow-up, but also to allow potential recruitment of people into clinical trials. And one example might be working very closely with the National Respiratory Audit Programme, thinking about how we might use that information and that data to develop cluster randomised controlled trials to be able to enhance data with routine data for longer term follow-up. One of the things that I'm really keen that we underpin all of this with is training. I think that from conversations I've had with people over the last few months, that people don't really understand the value of or how to access and use a lot of these data. So we certainly want to do a lot around training and signposting, and these are some of the aspects I'd really value people's thoughts on and feedback following on from this webinar. I mentioned earlier the Master's Scholarship. So we have 3 who are respiratory data focused, Mia, Lisette and Amy, where they've been sponsored by Health Data Research UK to undertake master's programs in health data analytics, statistics, epidemiology, for example, and they will have respiratory focused projects which will help to feed in to using and improving the quality of data. And my final point here is involving people who are affected by poor respiratory health. We recognise the importance of incorporating diverse perspectives and getting patient and public perspectives to really enhance our outcomes. And at this point, I'm going to ask Victor if he'll say a few words about how patients and the public are going to be involved in the Respiratory Data Hub.
Hi. My name is Victor. I have COPD, I have emphysema, and also the chair of one of the support groups which Asthma and Lung UK have all over the country. Mine's based in Stoke-on-Trent. And I'm very excited about this data initiative. I think it's something which we really need. maybe just some words just about having the illness with lung conditions. With the lung conditions, in my case, I'm mild, moderate. I've high 70% of lung function still. I have an inhaler, the bronchodilator, which is what's recommended. But nonetheless, although the breathlessness is stable, there's still I have no stamina. I can't do anything strenuous. The functionality isn't there with the lungs, and sometimes I might get tight-chested or breathless without reason, in fact. And this can make you quite enclosed in terms of anxious in enclosed spaces. So this is limiting for travel, for instance, trains and planes, etc. And in fact, most evenings I have inflammatory chest pains, which is not really explained. I do all the recommended things for people with lung conditions in terms of self-management, in particular exercise. I do lots of exercise, swimming, exercise classes and the things. And indeed, even with the group, we've set groups up, exercise groups up, so that everybody can do the same. And we have specialist speakers so that everyone can be aware of the best self-management practices. So we all do our best to do what's recommended in terms of looking after our health, inhalers, exercise, etc. But a key issue is that we don't know how our disease will progress, because in fact no one can tell us. Nobody knows. We don't know the mechanism of emphysema. We don't know how to treat it. Therefore, what we're doing is we're actually looking after symptoms, and we're preparing our body to get better at living with the deteriorating lungs. And we just have to wait and see. So this is not necessarily very optimistic. We have a permanent underlying anxiety, I would say, because we don't know about the future. And this is not just us, of course, it's family, it's wife, kids, loved ones. So this is the reality of having a lung condition, when in fact it's we're not treating it, we're just living with it. So this is important just to recognize for all the millions of us that we are. If I talk about the diagnosis, I mean, I first had lung symptoms in April 2020, and that's nearly 17 years after I stopped smoking. And in fact, my first symptoms were I couldn't breathe when lying on my back at night. And my consultant said that's not a normal symptom, but in fact, I've met a number of people who've had exactly the same first symptoms. But I don't think this sort of thing is recorded. It's kind of things like this is kind of, to me, is really kind of lost data. In the groups, we talk quite a lot about different chest pains, about different things which occur, which are not explained. And often what we hear is simply, it's very individual, and there's not really anything to do with. I think here's something which is lost. I think there's a problem that the GPs don't have many options. It's basically inhaler and do your exercise. So much detail is lost, I think, in that, which could be useful in terms of better understanding, diagnosing our conditions. As I said, my condition started in 2020, at the beginning of the pandemic, which was obviously a bit awkward, but nonetheless, it's still unsatisfactory diagnosis, because at first it was maybe COVID, so just wait and see. Then they suggested antihistamines for some reason. Then they decided it should be maybe adult onset asthma, so taking inhalers for that. All this without seeing a GP, and this over some number of months. And during all this uncertainty, of course, you're looking at Dr. Google and the like, getting very scared about what's going on. And because of the pandemic, to get some real tests done, it would have taken, well, it wasn't offered. In fact, it would have been maybe a year to get a first even X-ray. So I was lucky enough to be able to go privately for the full consultation, CRT scans and spirometry, just to define after a number of months that I had actually emphysema. I'm in Stoke-on-Trent. It's a 12th deprived area of the country. Most people can't afford to go privately to get complicated diagnoses done, just to find out the basic what's wrong with you. Many people in the Breathe Easy groups, there's talked about being on asthma treatments when in fact it's eventually discovered it was a COPD or other lung condition. or they've had waits of years to get a spirometry, or even, in fact, one chap's waiting 10 months to get the results of his spirometry. So it's not good. There's got to be better ways to diagnose with simple tests, with better data and tests for people to do this. Just some reflections that, as I mentioned, first symptoms I had was 16 years after stopping smoking. So for 16 years at least, my body was already with emphysema and developing the emphysema. So during this period of time, I've had lots of blood tests, I've had lots of scans and tests for other things, and nothing's ever been picked up. But I think no one's probably even been looking. So I think there's going to be markers out there. There's going to be indicators for people which are not being looked at, not recognised, which in fact is a missed opportunity totally in terms of data and for treatment. And another thing is that I, like 90% of people with COPD, have multiple conditions. So in my case, I have ankylosing spondylitis, the kind of joint issues, as well as blood pressure and cholesterol. My consultants don't talk to each other routinely. They're very much in their silos, and even I think the rheumatology doesn't have the same IT systems as the heart and pulmonary systems. So here, everyone's in isolation, and I don't believe, in fact, that these things are in isolation. I think that we're as people, we're interactive biological systems. We're not independent mechanical parts. So I think the other thing which is really important with this possibility, with this data, and especially the broader view, is to take a much broader view of the person and all the things that's wrong with them at the same time, to identify the linkages and how it works together. So all of these points to say that there's a great deal we need to do to actually better manage and understand and treat the lung conditions. But I'm excited by this program because it's so needed, and you know, joining the dots, getting us some answers, and giving us I have to say giving us hope in terms of the future. So really want to give out absolute support and best wishes on the project. I think it's important.
Thanks very much, Victor. Can I ask Sarah and David to turn their cameras back on, and we'll go through some of the questions that have come in, and do keep them coming in while we start answering them. So the first one I'm going to direct towards Sarah, actually, which you may or may not want to answer with an active grant call out at the moment. But the question is, what are the key research priorities and research questions to be addressed using data science from Asthma and non-UK's perspective?
Well, the first thing I would say is, which is a slight dodge, but I think one of the things that the charity can do is invest in an infrastructure which in itself will help to drive research. And I said that it's definitely an underinvested research area in terms of respiratory. And one of the things is that if you are a young up-and-coming respiratory clinician stroke researcher, you're going to want to know that the career that you're going into is going to be able to provide you with exciting opportunities. And there are a number of things that you need for that to be the case. And one of them is to have essential tools at your disposal. And data is an absolutely fundamental tool that is going to be required to drive, you know, excitement and innovation in this space. So from that point of view, just the mere fact of investing in this as an infrastructure piece is a priority for the charity, because it will inevitably drive more research later on down the line. I think we've talked about the sort of need to link data sets, and we've talked about the need to use that to drive not just medical research but also service improvement. Currently, the charity is looking very much at diagnostics. Some of that is about completely different approaches to the way that we do things currently, and it will be, you know, sort of technological advances, etc., and it's got its own pathway. But it's also about using what we've currently got much better. And I think you talked about this, Jenny, we just don't know how things are being used at the moment and where there are big gaps. And this will really be able to shine a light on that and enable us to work with system leaders and to work with clinicians to say, this is what's going on at the moment. We could deliver this so much more, you know, to greater effect. So diagnostics is quite key to the organisation at the moment. We know that loads and loads of people are going without a diagnosis. And if you can't get a diagnosis, you can't even start treatment. We're also looking at a very broad and encompassing theme around breathlessness. And we've recently carried out a prioritization exercise using, some of you will be very familiar with the James Lind approach of helping all the stakeholders, patients, clinicians, researchers, identify the unmet needs and then prioritize them. Now, what was interesting from that is many of the unmet needs are actually not necessarily about give me the cure, give me the, you know, the exciting new medical treatment. A lot of it is about enabling me to live and manage the conditions better. Now, you can only really look at that if you have the data and masses of data to sit behind it, to really disentangle all of the various variables that might be impacting on outcomes. And so, you know, this kind of data linkage that we will be able to achieve with this and bring in things like primary care data eventually as well will be fundamentally important to really helping people deal with general issues around breathlessness. So I've kind of not said what necessarily my fave priorities will be, because we have got, and I don't want to steer anybody particularly for a data research call out, but that kind of gives you an idea of the broad brush.
Thanks very much, Sarah. I'm going to rattle through a couple of the other questions that have come in, and then David, I'm going to pass one over to you for the final question. So somebody's asked here, will the Data Science Catalyst be supporting young researchers pre-doctoral and doctoral level? The answer to that is absolutely. And we are already, by having these master's students who've had master's courses funded through HDR UK, and then working very closely with the Respiratory Data Catalyst for their projects. As you'll know from Asthma UK's grant call that is out, there is a specific call which is focused on PhD projects. So absolutely, and please do get in touch. And I'm delighted to chat further about that. I'll put up the contact details at the end. Definitely plans to include primary care data, and there are a number of bespoke data sets available. For example, cystic fibrosis data through the Cystic Fibrosis Trust, which can be accessed for research purposes. And again, delighted to chat through how to go through that application process if that's helpful, because a lot of the times I think it's just people not necessarily knowing how to access data. So David, I'm going to pass the last question over to you, which is one about a federated learning model. So asking, will UK-wide data sets be available or permissions required on a per trust level? And I think this probably counts broadly across HDR UK. So I don't know if you just want to briefly say something about HDR UK and federated analytics.
Yep, very quickly, thank you. I mean, I guess unfortunately the answer is probably it depends. So it depends on the data assets. So we're working within England very closely with the NHS Data for R&D programme, which is looking particularly at surfacing data assets that would traditionally only be available at a trust level, and that they're made available in a more consistent way. It may still be in a federated learning way in terms of a sort of a system that works across those different data assets, but you don't pool the data all together. In addition, the Coalesce study obviously worked across the 4 national sort of data collections, data sort of research environments, again in a federated way, but not in an automated federated way. And as Jenny says, we have a programme through both our core funding around federated analytics and to make that as efficient, as effective as possible, but also linking to sort of beyond NHS data. There is the DARE UK programme, which is also looking at enabling that. So I think it's a sort of more complicated answer than probably ideal, but I guess it's a key area of work to make sure that on the whole, the data remains sort of in situ and the code and the analysis moves to the data and in a more federated way.
Brilliant, thank you. So I just want to close this webinar now and thank Victor, David and Sarah for joining me. Thank all of you for joining. We had nearly 200 people register for the webinar and your engagement and questions was fantastic, so I didn't have to show you holiday pictures instead. I've put a slide up just with details of our webpage so that you can have a look at that and see opportunities as they become available, and also the email address for getting in touch with the Respiratory Data Catalyst. That's there at the bottom of the page, so that's respiratorykatalyst@hdruk.ac.uk. We will be involved, we'll be advertising for some posts in the not too distant future, and we will put all of our information regarding the webinars that we're going to be running on our webpage. And please do just email the Respiratory Catalyst email or me personally if there's anything that you think of, because in order for this to be a success, it really needs to engage the wider community. So thank you all very much.